Good morning, Doc. This is a case that you wanted me to look at, a Invisalign case, to try to gain a better sense on how to do this predictably. So this is a 30-year-old female looking to straighten her teeth. She does have some TMD and some bruxism, which you had highlighted might be fixed by the ortho, which can be true, but we want to be careful about being much more cognizant of the patients in the specific diagnosis that are likely to be successfully treated with ortho with respect to bruxism and TMD. So here, let's just take a look at what we have. So we always want to look at what the sagittal occlusion or malocclusion is. Patient is molar class 2, canine class 2, which isn't surprising that we see an overjet and an overbite. Class 2 patients anteriorly, we tend to see, 80 to 90, sometimes 100% overbite, which is not uncommon. These patients tend to have more wear as their jaw just doesn't really move as freely as the vertical dimension doesn't allow them to clear the upper anterior teeth as well. So is that the reason for her bruxism? Probably not. With that said, not surprised to seeing wearing, even though the lower anterior teeth are pretty far away. And this just has to do with the fact that their envelopal function is restricted. So class 2 on the right side and the left side. So the tendency here is to want to say to the patient, what would you like? Now, this patient probably doesn't know they're class 2, and fixing their class 2 doesn't mean everything goes away. So that treatment goal of fixing the sagittal correction isn't necessarily always what we're looking to do, but we need to know it's there. And if it is, do we treat it or not? In an adult, the Airway motion appliance, for me, has been the most predictable way of fixing the situation. The Airway motion appliance you can find on Henry Schein's Ortho website, or just type in Airway motion appliance sagittal ortho corrector, and you can learn more there if you wanted to. For a multitude of reasons, I don't think we're necessarily going to use that tool with this patient. With that said, it's a tool and it works wonderful in adolescents, but definitely with adults. So that's the first thing I'm going to look at. The second thing I want to look at, how's their arch width? As we looked at in our Nikkei Airway series, we want to have 38 millimeters in between the upper first molars. So here we have 10, 20, 30, looks about 33. So she's got a mildly restricted airway that may or may not be contributory. We'll come back to that. But I always want to get a sense of where I'm at with that. It's easy to straighten teeth. It's hard to use orthodontics in a way that actually positively affects their life. So here we have molar class 2, canine class 2 on both sides, deep overbite. We have some attrition. We have TMD and bruxism. Well, I always want to look at airway. So we looked at the palatal vault. It's somewhat restricted. If this was 25 millimeters, then I'm definitely going to expand the upper arch using Miraglia's tools to expand the upper arch. Might do some MSC or some MARPI or SARPI. When do we expand the upper airway? Topic for another day. I don't think this is a patient we need to do it, but I think it's a patient we should consider it. Well, let's take a closer look at her airway. So here's her sagittal or side view. This should scream forward head posture. 100% forward head posture. How do I know? Here's her shoulder. So if we draw a vertical line above the midline of her shoulder, her ear is very anterior to that. You can see that her forehead has kind of a steep angle, which is what happens when people posture their head forward, as the angle of their forehead starts to get more and more shallow to the horizon. It just screams forward head posture. She's also somebody, a female having, a 17 or 18-inch neck, has a drastically increased likelihood of having OSA, obstructive sleep apnea. I would be surprised if this patient doesn't have sleep apnea because of the forward head posture, the large neck, the bruxism, the TMD, and several other factors. I don't have any pictures of the scalloping of her tongue. If that was present, that would be another confirmatory factor to suggest that there's probably an airway component here. So I think you see where we're going with this. Also, I'd want to see if there's a tongue tie. This is on Zagi's website. ZAGHIMD.com. Click on tongue tie. So the functional tongue tie classification, this is a little bit different than the tongue tie classification that oral surgeons use to assess whether a patient or a young child has feeding difficulties. This is kind of the new age myofunctional therapy airway classification of ankyloglossia. So they're different. Just know there's different classifications out there. You should know all of them if you're going to start to dive in this arena, which I can't imagine any dentist not understanding this stuff because it is so damn relevant. So she's probably kind of in this grade 3, grade 4. What you do is you have the patient open as wide as they can, lift the tongue to the roof of their mouth, and then you take a picture, you measure what is the percentage towards the incisal edge of 8 and 9. So this would be above 80%. That's very good. Most patients that are decent are going to end up in this area. The majority of people, including myself, are kind of in this mid-range here. Keep in mind, if you ever do tongue tie releases, 1, you should know how to do it, and 2, you should have a myofunctional therapist that keeps you successful, because releasing the tongue is like releasing a 5-year-old on a highway with his 2-wheel bike. What do I mean by that? The tongue has no idea what to do after you release it. You have to teach it what to do. It has to become mature in this process, and that's where myofunctional therapy comes in. Releasing alone can actually cause the tongue to go backwards and make the problem worse. Not everybody. Some people you can release and it changes their life. So just be careful. There's a lot to this world. I wouldn't be surprised if this patient has some sort of tongue tie. So coming back to the clin check, there's 2 ways of going about this. You can just straighten the teeth, or you can actually get a full assessment of what's going on. So be careful. When we use the diagnosis TMD, TMD is a collection of diagnoses. Myofunctional pain disorder, or MPD, is probably synonymous to a great degree with TMD, in great part because most TMD is myofunctional pain disorder. Those are the people whose masseters are tired and trigger points happen, sending pain to teeth. We see these in the practice all the time. But there's a whole other set of conditions, intracapsular conditions, they also fall under the category of TMD. So before we treat a patient like this, we really have to be clear on what the diagnosis is. My guess is it's myofunctional pain disorder, only because that's the disorder that tends to come along with airway patients. With that said, we really need a CAT scan of the joint to make sure that we're not missing some intracapsular diagnoses. Myofunctional pain disorder can actually be several diagnoses, especially in airway patients, where you can have osteoarthritis of the condyle, anteriorly displaced disc, and myofunctional pain disorder all in the same patient. Those are all forms of TMD. All right, so this looks like a simple case as far as straightening the teeth, but as you can see, it's actually really complicated, and one that we should be able to navigate very predictably if we understand all of these avenues, which is what makes us a comprehensive clinician. So back to the treatment. What do we do? How do we treat this patient? So the way I would go about this is, 1, does she have obstructive sleep apnea? Has that been diagnosed by her primary care physician? So that'd be step number 1. Step number 2, if she has not, whether you are set up to have an HST or home sleep test done in concert with a sleep physician so you can get an actual diagnosis, this would be a great patient for that. In our office, we have that set up through Sleep Group Solutions, who's a company that trained us on how to do this. There's many out there. The point is, we need a diagnosis about her airway from a sleep perspective. Is she sleeping well at night? Because what happens with these patients when they're struggling to sleep, they increase their sympathetic tone. That increase in sympathetic tone tires the muscles out. That's where the MPD, or the muscle component, comes from. The muscles are just firing all night long because the body's in a sympathetic state when it's supposed to be resting in a parasympathetic state. The muscles of the jaw, the masseter, the temporalis, the medial and lateral pterygoids, they just get tired, and they express themselves as pain. No different than if you stood on your left calf for an entire day, it would hurt. So getting that data of sleep apnea, obstructive sleep apnea, or central sleep apnea for some patients, or other sleep diagnoses, is important. We have to loop in our sleep physicians to help us with that. So once we figure that out, let's just say the patient does have sleep apnea. 99% sure this patient has it. Could be mild, could be moderate, could be severe. My guess is this patient's on the moderate to severe end. If they have it and they're wearing their CPAP, I would probably have the sleep physician titrate their CPAP, or work with the sleep physician saying, from our perspective, it does not seem that this patient is titrated well. When we see scalloping of the tongue, when we see bruxism, when we see TMD in an airway patient, more often than not, the sleep physician did what most sleep physicians do, is they test the patient, prescribe a CPAP, and then the patient goes 10 years without ever getting titrated again. It's a big black hole in the system. Some sleep physicians are better about it. They just don't get paid for it, so it tends not to happen. Therefore, there are a lot of patients with CPAPs that are not actually treated that well. They might be a little better, but not as good as they could be. So working with your sleep physician is an important part of this. So get all that figured out, get the sleep optimized. Then see if there was some treatment done, if the CPAP was changed, did the TMD change? So what we're trying to do here is rule one thing out at a time. If we just do ortho in hopes of fixing this patient's TMD, we're really muddying the waters, because we might actually make the TMD worse for a multitude of reasons. We don't want to do that. So we get the sleep test figured out. If it hasn't been done, we get it done. Then we get to a point where, okay, now we have data. This patient is struggling to breathe. How do we optimize this patient's orthodontic plan? And there's many ways to go about it depending upon the data that we get. So what I'm advocating for here, let's not focus on how to straighten these teeth. We have other videos to talk about that. This is a patient, we have to pump the brakes, back out, widen the periscope a little bit, and look at the patient's airway. I can almost promise you can change this patient's life by bringing some focus and attention on it. And I'm going to end with the following. So many of these cases in my hands, when I was a younger clinician, I used to say, the patient only wants to straighten the teeth. And as I've mentored more and more associates and clinicians through this channel, it's become very evident that we tend to fall on that when we're scared or don't understand all of the stuff I just talked about. It took me 17 years to understand this stuff. It's rather in-depth, but don't let that dictate the treatment plan into, I'm just going to do what the patient wants. The patient doesn't know any better. So if we can't articulate what their problems are and what the pros and the cons and the value and the benefit on the other side are, then we're probably just going to say, well, that makes a lot of sense. Let's just straighten your teeth. Oh, we could fix the TMD. We could fix the bruxism. Those things might happen. Yeah, I mean, that's throwing darts at the dartboard blindly. I think we can do better. So let's get the airway figured out. Once we get more data from the airway, then we can proceed forward on how to navigate this patient accordingly. So I hope this helps. I'm going to end with one last comment. Does occlusion cause TMD? Dawson used to say yes. Many clinicians historically thought this was the case. The literature kind of flushed this out. Now the majority think they're not connected. My personal opinion is they're connected in some people, and those are people that splints work well on, T-scans work well on, quick splints, so on and so forth, aqualizers. Those are people that if you free up certain things do improve, and these are also people that ortho might improve. But we want to know that ahead of time and not after the fact. So does malocclusion cause TMD? Something we should all understand what the opinions are out there. And I'm going to refrain from going too deep down that trail. So I hope this helps. Stay in touch. Let me know how the patient proceeds. Let's get that airway figured out. Take care.